Hello, I'm Diane Huber, and this is my snippet on the pharmacologic treatment of hypertension. I will focus on first-line drugs prescribed for this disease. So, hypertension is a condition in which the arterial blood pressure is persistently elevated. Our blood pressures are measured with a special cuff that goes around our upper arm. And as we inflate the cup and then slowly deflate it, we listen for the heartbeat when it starts and stops. The top number is the systolic value, or the systole, when the heart is pumping blood out into the circulatory system, and this is the maximum pulse pressure against the arterial walls. The lower number is the lowest peak pressure when the heart is at rest and refilling with blood. When arteries have lost some of their elasticity and become harder, those pressures can increase due to the inability of the artery to elastically respond to the increased pulse pressure during systole. So as arteries age, they can become less elastic due to arteriosclerosis. So our classification of our blood pressures are normal, pre-hypertension, stage 1, and stage 2. And the treatment that is given for these depends on the level of hypertension and history of the patient. And this is a common disorder that affects about 30% of adults in the U.S. It can be asymptomatic but can progress to heart disease and stroke if untreated. And is a risk factor for developing chronic kidney disease and heart failure. Any system that is hemodynamically sensitive is affected by blood pressure. It can occur secondary to other causes, but most commonly it has an unknown etiology, and we call this essential hypertension. And this is the cause of about 90% of cases. And a family history of hypertension increases the likelihood of developing it. When our blood pressure becomes so elevated that our systolic is above 180 or our diastolic above 120, this is a hypertensive crisis. It is an emergency situation and requires hospitalization for treatment. So there are a wide variety of pharmacologic options to treat hypertension based on the assessment of the patient's condition, stage of hypertension, comorbidities, and any contraindications. Our typical first-line drugs are ACE inhibitors and ARBs, or angiotensin receptor blockers. Lisinopril is one of our most common ACE inhibitors, and valsartan one of our commonly prescribed ARBs. So our ACE inhibitors inhibit the angiotensin-converting enzyme, and this reduces the activity of the renin-angiotensin-aldosterone system. It also increases the levels of bradykinin, which allows more vasodilators, such as nitric oxide and prostacyclin, to form. So it works by blocking vasoconstriction activity of angiotensin and increases vasodilation activity. Our ACE inhibitors also reduce sodium in water and reduce cardiac preload and afterload. Common side effects are dry cough, rash, fever, altered taste, hypotension, and hyperkalemia. Our potassium levels should be monitored while taking ACE inhibitors, and some patients may experience angioedema due to the elevated bradykinin levels. The most common side effect is a dry cough. Our ARBs lower blood pressure by decreasing the activity of angiotensin II. They do not affect bradykinins. They are used in patients with comorbidities such as diabetes, heart failure, and chronic kidney disease. Like ACE inhibitors, ARBs decrease salt and water retention, and their common side effects are similar to ACE inhibitors, with a lower chance of having an angioedema or a dry cough. ACE inhibitors and ARBs are not used with each other due to similarities in adverse reactions and their mechanism of action, but the choice depends on our patient's comorbidities and any previous reaction to one of these drugs, such as a dry cough or angioedema. In those patients, an ARB may be a better choice. So for genetics, there is a genetic link because a family history of hypertension increases your likelihood of developing it. Environmental conditions such as inactivity, stress, obesity, tobacco use, age, salt in the diet, and alcohol consumption all play a role in hypertension. There's a higher incidence of hypertension in non-Hispanic blacks than in whites, Hispanics, and Asians. And Hispanics are at a higher risk than whites. There were no gender differences within races and Hispanic origin groups. So that concludes my snippet presentation on the pharmacologic treatment of hypertension. Thank you for listening.